Hello, I'm here today with my good friend Tom Schwartz, and we're going to be talking about his talk at this year's NEI Congress. And his talk is entitled Nothing Personal, Diagnosis and Treatment of Personality Disorders. Now, we don't get a lot of talks on personality disorders these days. And of course, we know that they are highly comorbid with other psychiatric disorders, and that can increase the complexity of the diagnosis and the treatment plan. So in this presentation, Tom's going to review the diagnosis, neurobiology, and evidence-based treatment options for personality disorders with an emphasis on borderline personality disorder or BPD. So Tom, tell me about this talk and why you're excited to give it.
Well, Andy, have you ever seen a brand new antidepressant come out, become FDA approved, and you're told it should work 70% of the time? And then in practice, it just doesn't seem to do that. How many of us just see somebody that just has depression? So over my years of practice, it's tough. People have trauma, they have personality traits, they have anxiety disorders, they have those comorbidities, and things just don't always work as advertised. So the sooner we identify personality disorder and try to treat it concomitantly, I think the better we do.
Yep, boy, that really makes sense. Tom, I'm thinking about how many times I've started treating a patient and it's not going well, and then all of a sudden I have that dawning realization, oh my goodness, this is a personality disorder.
Yeah, no, absolutely. Yeah,
so
happens.
It does. And what can we do about that? What are some tips or some takeaways maybe for the audience?
So if we could go back to the old days where, let's say as a psychiatrist, I saw patients weekly, you have more data points, right? You would pick up that diagnosis so much faster. But in the era where many psychiatrists are solely doing medication management every several weeks, you just don't get the data points. So one of the biggest things we can do is talk to the outside therapist. I don't know if we're the best group at communicating routinely, maybe the primary care physician, but the more people you talk to, you see those personality disorder patterns. And I think that's a key way to do it. There are rating scales for BPD and other disorders. So, using rating scales that are simple and easy to use. Part is detection, right? You need to make a good diagnosis, and that sets you on course to a better treatment.
Yeah, you mentioned therapist. I guess really the best treatments are longer-term psychotherapy kinds of interventions coupled with appropriate medication. Am I right?
Yeah, I think so. If you look at the evidence base and the outcomes-based literature, certainly, DBT, dialectical behavioral therapy, has a ton of research. I think psychotherapy, like pharmacotherapy, has a dose and a duration. And I find, unfortunately, some of the DBT protocols are not once-a-week individual therapy plus once-a-week group therapy. And then the DBT team meets once a week. There's kind of these 3 doses for full-dose DBT. And just like meds, if you don't dose it right, you may not get your outcomes. So I'm a big proponent of doing it the way the book says. Psychodynamic psychotherapy, certainly can be effective. We have a researcher here at Upstate, Dr. Gregory, does something called DDP, validated form of psychotherapy, psychodynamics for borderline patients, which is pretty effective. Other psychodynamic approaches work, but I think those are the 2, maybe more than our meds, that have better outcome data.
Yeah, that's certainly true. But I think also judicious psychopharmacology, right? I mean, we want to do no harm, but also maybe intelligent use or evidence-based use of psychopharmacology can help.
Yeah, I think it's hard. What I notice with patients, either, maybe they're on one medicine or too few, we don't address their target symptoms, or they're on several, which is too many.
Yeah.
So I think judicious is, maybe somewhere in the middle. And again, you can use a categorical approach. Do they have depression? Do they have panic? Plus the personality, you can treat per the kind of the DSM, FDA approach. Or do they have a major symptom like mood lability, mood swings? It's not really bipolar, but we have meds that treat lability. And I call that a target symptom approach. And I think you got to be in the middle. Right? You can't undertreat, don't want to overtreat, but you have to take an approach and stick with it.
Boy, I love this, Tom. I mean, this is really challenging all of our skills here. What is going to be surprising to people as they come to this talk?
So, I grew up in an era where, you really weren't supposed to diagnose a personality disorder till after 18. You were supposed to see the patient for a requisite amount of time. And I think that would delay us making those diagnoses. I think a key thing is using some stringent measures, making the diagnosis sooner, and getting the patient to, the best outcome-based treatment you can. So I do think we're going to talk about that and diagnosis and accurate diagnosis. I think like everything else, the brain's probably doing something wrong. If you have circuits in the brain that are too hyperactive or too underactive, you see symptoms on the outside.
Yeah.
So even though we view personality as a psychological phenomenon, there are biological underpinnings. So I think that's kind of cool to talk about too.
Yeah, I agree with you. I was taught that psychotherapy is a form of biologic treatment. In a way, you are helping to rewire the brain.
Yeah, no, I think you're right. And, is it glutamate? Is it long-term potentiation? Are you strengthening the DLPFC? Yeah, all that stuff, probably in the mix. Absolutely.
Yeah. Well, obviously, when we're talking about personality disorders, we're talking about maladaptive kinds of coping mechanisms. And I think I did a podcast, of course, with Dr. Stahl on neuroplasticity, for good or evil. I mean, not all neuroplasticity is good. You can hardwire maladaptive kinds of behaviors.
Yeah, absolutely. Yeah. And, I think somehow, we all grow up, we all have different experiences, good ones, bad ones. We all have different levels of resiliency. And, who knows why we develop the coping skills or the repetitive things that we do that get us in trouble. I view personality disorder, folks, as kind of creating an unrelenting stream of adjustment disorders. If you like that DSM term, right? It's their interpersonal conflicts puts them in stress again and again. And we know stress drives up cortisol, and cortisol shrinks the brain and makes us have less plasticity, right? It all adds up. It all makes sense to me that way.
Yep, I think 100% true. And I'm really excited for you and for this talk and for our audience to hear about there's some newer approaches, newer ways of thinking. And so I hope you'll join us at our Congress in Colorado Springs this November of 2023. Tom, thanks so much. Great talking with you.
Hey, thanks, Andy. Take care.